This is the second video of the abdomen series. In this video, I will introduce you to the concept of peritoneum, the greater sac, the lesser sac, greater omentum and the lesser omentum. After that, I will describe the structures that are derived from the foregut, midgut and hindgut, and that will be starting from stomach, duodenum, pancreas, liver and spleen, then jejunum, ileum, cecum, and then ascending colon, descending colon, transverse colon and sigmoid colon, and lastly the rectum. At this point, I would like to give you a simple introduction to the embryology of the gastrointestinal system. In utero, the entire gut tube is suspended by dorsal and ventral mesentery inside the peritoneal cavity. A ventral mesentery suspends only the proximal part of the gut tube. As the embryo and fetus develops, the gut rotates, loops, and sections of the visceral peritoneum fuses with the parietal peritoneum. Thus, sections of the gut tube becomes retroperitoneal while other remain intraperitoneal. The abdominal cavity is lined by a serous membrane, the peritoneum, similar to pleura and the pericardium. It has two layers, parietal peritoneum and the visceral peritoneum. Lining the inside of the anterior abdominal wall, here is parietal peritoneum. Here is the visceral peritoneum covering the viscera. The peritoneum forms a closed sac called the peritoneal cavity. The sac contains a serous fluid, peritoneal fluid, that prevents friction and helps to keep the viscera mobile. The two folds of visceral peritoneum here makes up the mesentery. The mesentery suspends the viscera in the peritoneal cavity and keeps them free and mobile. The mesentery is attached to the posterior abdominal wall and conveys the blood vessels, nerves, and lymphatics to the viscera. The mesentery that connects two viscera is called omentum. The lesser omentum connects the liver to the stomach, and the greater omentum connects the stomach to the transverse colon. Structures that are surrounded by visceral peritoneum are termed intraperitoneal, like the stomach shown here. Structures that lie between the parietal peritoneum and the abdominal wall are retroperitoneal, like the pancreas shown here. This large structure that is seen first in the peritoneal cavity is greater omentum. It resembles an apron and drapes from greater curvature of stomach downwards and then back up to the transverse colon, covering the intestines. It is filled with fat in obese individuals. Its function is to protect the intestine and localize infection and tumor and stops it from spreading. It is sometimes referred to as the security guard of the abdomen. This is the lesser omentum. On the right, it is attached to the inferior surface of the liver, and on the left to the lesser curvature of the stomach and proximal duodenum. This segment of the lesser omentum is called the hepatogastric ligament, and this section is the hepatoduodenal ligament. The peritoneal cavity is divided into greater sac and lesser sac. My hands are in the greater sac. This is an area between the anterior and posterior layers of parietal peritoneum. The lesser sac is a small space within the greater sac, posterior to the stomach. These two sacs connect via an opening from the greater to lesser sac called the foramen of Winslow. My probe is in this foramen entering the lesser sac. The free edge of the lesser omentum contains three important structures: the portal vein, the hepatic artery, and the bile duct. The collective name for these is the porta hepatis. This is the hepatorenal recess where the fluid within the abdomen may collect. In this prosection, the surrounding fascia and peritoneum has been removed. This is the lower esophagus. At this level, the esophagus is composed entirely of a smooth muscle. This is where the lower esophageal sphincter is, but it is within the walls of the esophagus. At this point, the esophagus enters the cardia of the stomach. This is the fundus of the stomach, the body, the pyloric antrum, and the pylorus. This is the cardiac notch, the angular notch, the greater curvature, and the lesser curvature of the stomach. The pyloric sphincter is a circular ring of smooth muscle that regulates the flow of the stomach contents into the duodenum. The transpyloric plane passes through this sphincter and is located at the vertebral level L1. On this stomach, a section of the stomach wall has been removed. These longitudinal mucosal folds are termed rugae. The stomach contains 3 layers of muscles. One has circular, one has longitudinal, and one has obliquely running fibers. Here the liver has been retracted and the transverse colon as well as the parietal peritoneum has been removed. The small intestine consists of, from proximal to distal, the duodenum, the jejunum, and the ileum. The duodenum is a C-shaped retroperitoneal structure into which the stomach contents pass. It has 4 divisions. First is the superior part, extending from here to here. It starts as intraperitoneal, but after this the entire duodenum is retroperitoneal. This is the descending part where the bile and pancreatic ducts enter the duodenum at the major and the minor papillae, which is not visible here. The horizontal part is inferior to the head of the pancreas. The fourth part, the ascending part, then becomes intraperitoneal. Here, at the duodenojejunal flexure, a suspensory fold of peritoneum, the ligament of Treitz, marks the beginning of the jejunum. The pancreas is retroperitoneal except for a small part of its tail. This is the tail of the pancreas, extending towards the spleen. This is the body, the neck, the head, and this is the encinate process. These vessels are superior mesenteric vein and artery. Notice that these vessels pass posterior to the neck but anterior to the encinate process of the pancreas. This is an important surgical landmark. The spleen lies anterior to the 9th to 11th ribs. Normally, the spleen does not extend below the left costal margin, even on inspiration, and its anterior tip does not extend beyond the mid-axillary line. This is the spleen. It lies posterior to the stomach. It is surrounded by visceral peritoneum, which attaches to the greater curvature of the stomach by the gastrosplenic ligament and posteriorly to the parietal peritoneum overlying the left kidney. This is the hilum of the spleen, where the blood vessels, nerves, and lymphatic enters the spleen. This is the liver, lying mainly in the right hypochondric region. It extends also into the epigastric and left hypochondric regions. Notice that the liver has a visceral and diaphragmatic surface. The ligaments, which are actually folds of mesentery, connect the liver to the surrounding structures. These ligaments should not be confused with the bony ligaments. The falciform ligament shown here divides the diaphragmatic surface of the liver into right and left lobes. The space between the diaphragm and the liver is called the subphrenic recess, and the space between the liver and the kidney is hepatorenal recess. The diaphragmatic surface of the liver is entirely covered in peritoneum. The liver is retracted, and this is a superior view. This is the gallbladder with its fundus, body, neck, head, and cystic duct. This is the porta hepatis containing the bile duct, portal vein, and hepatic artery. Here is the ligamentum teres at the inferior edge of the falciform ligament. Here is the fissure of the ligamentum teres, continuous with the peritoneum surrounding the porta hepatis. Here is the left lobe and the right lobe. This is a postero-inferior view of the isolated liver. Here is fissure for the ligamentum teres, porta hepatis, quadrate lobe, left lobe, right lobe, and the caudate lobe. This is the fissure for the ligamentum venosus, and it is also where the lesser omentum attaches. This fissure opens up to form a bare area that is not covered by peritoneum. Tracing the boundaries of this bare area, we have the left triangular ligament, the falciform ligament, the anterior coronary ligament, right triangular ligament, posterior coronary ligament, and the inferior vena cava. The inferior vena cava receives blood from the liver at this point. Bile drains from the liver parenchyma into ducts. Here is the right and here is the left duct. These two ducts join to form the common hepatic duct, which then joins the cystic duct from the gallbladder. This is the common bile duct. This is the hepatic artery, and this is the portal vein. The omental foramen or foramen of Winslow is posterior to these structures. The common bile duct passes posterior to the duodenum and joins the main pancreatic duct. This forms the ampulla of the Vater and drains into the descending part of the duodenum at the greater duodenal papilla. The sphincter of Oddi surrounds the orifice of the ampulla of the Vater. An accessory pancreatic duct may empty into the lesser duodenal papilla. These structures are not visible here. These are the loops of jejunum and ileum, which lie entirely intraperitoneally. The first few loops are jejunum and the rest are the loops of the ileum. Roughly speaking, the jejunum makes up the proximal 2/5 and the ileum makes the rest. There is no sharp distinction between these parts. The jejunum begins at the ligament of Treitz and the ileum ends at the ileocecal valve here. Comparing the two, we see that the jejunum is wider and has a thicker wall than the ileum. Let's see the blood supply of these two areas. The blood vessels that course through the mesentery are arranged into these arterial arcades, and these are vasa recta. The jejunum has long vasa recta and short arterial arcades. In comparison, here in ileum, there are short vasa recta and long arterial arcades. These mucosal folds are placa circularis, and since they are visible on the abdominal radiographs, are important features when identifying the small bowel. The large intestine begins here at the terminal ileum and forms the cecum, an intraperitoneal structure. It lies in the right lower quadrant in the iliac fossa. The ileum partly invaginates into the cecum, forming two folds above and below the ileocecal orifice, making the ileocecal valve not visible here. Here is the appendix. It suspends from its own mesentery from the terminal ileum. This is called the mesoappendix. The position of appendix relative to the surrounding cecum, ileum and pelvic brim is variable. Clinically, McBurney's point is used to locate the position of the appendix. This point is 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Continuing along the large intestine, here is the cecum, the ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. The ascending and descending colons and rectum are retroperitoneal, and only their anterior surface is covered by peritoneum. The cecum, transverse colon, and sigmoid colon are intraperitoneal. The sigmoid colon becomes the rectum at a mid-sacral vertebral level. There are two important flexures of the colon, the hepatic flexure and the more superior splenic flexure. These depressions, posterior and lateral to the ascending and descending colon, are paracolic gutters. I will now show the features that distinguish the small bowel from the large bowel. First, the large bowel has three distinct bands of longitudinal muscle fibers, the tinea coli. Second, there are pouches of fat hanging from the large bowel called the appendices epiploici. Third, there are characteristic sacculations between the tinea called hostrae. Hostrae are visible on abdominal radiographs and helps identify the large bowel. Notice here the diameter of the colon is smallest at the sigmoid colon, and therefore this is clinically important because it is a common site for large bowel obstruction.